Hello everyone. Welcome to my class on Introduction to Pain. My name is Dr. Mohammed Ali Kamal, and I'm excited to discuss this very critical topic with you guys today. Let's start by understanding the importance of pain management in palliative care. Pain is a complex and very subjective experience. As we often say, pain is what the patient says hurts. This quote emphasizes that pain is not just a physical sensation, but personal experience, and that can affect a person's overall well-being. What we mainly do in palliative care here is the first rule of even pain management is we should believe the patient. So pain is what the patient says hurts. How can we define pain? I want this to be an interactive session, so if anyone can answer. How can we define pain?
Please put your answers
Okay.
in the chat box, or you can unmute yourself and talk.
Okay. The International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with or even resembling associated with actual or potential tissue damage. This definition highlights that pain is not just a physical sensation, but also an emotional experience. We can think of pain like an iceberg. The visible part above the water represents the physical sensation or the physical pathology, while the larger hidden part beneath the surface represents the emotional and psychological aspects. The features of pain. Pain is always a very personal experience. Pain and a nociception are different phenomena. Life experiences influence pain perception. Can any one of you share an example of how life experiences might influence someone perceiving pain? An example for a life experience that might influence how someone might perceive pain. Okay, let me give you an example. We can consider two individuals experiencing a similar injury. For example, a sprained ankle. The first individual who could be a professional athlete who has experienced numerous injuries throughout his career, he may perceive the pain of a sprained ankle as relatively minor injury. He might have a higher pain threshold. He also could have higher resilience. So also his frequent exposure to pain also could make him perceive the pain as a mild inconvenience to him. He might also have a clearer recovery plan, which might also reduce the anxiety and his emotional distress. Now, the second individual, a person who has never had a significant injury before, he might perceive the same sprained ankle as extremely painful and distressing. He or she could experience more fear and more anxiety about the injury because it's an unfamiliar situation for them. This emotional response can amplify their perception of pain, making it feel more severe. So that's how we can also, how can we give an example? We can compare this to experiencing turbulence on a flight. A frequent flyer might remain calm and perceive it a minor inconvenience. It won't affect him much. But while someone who rarely flies, or if it's his first time, he could be extremely anxious. He could have fear because he hasn't experienced a similar kind of situation. This example shows how personal history and emotional context can influence the pain perception. It can also remind you that when we are assessing and managing pain, we need to consider the patient's each unique patient's unique background and his unique experiences. The next point, we must respect how each patient expresses their pain. Can any one of you give an example how different each patient expressing pain would be? Different scenarios, two different scenarios. You can give anecdotes, your stories. No one? Everyone's silent. Ma'am, is there? I can't see the chat. Is
No,
someone
no.
replying?
We haven't received any chat. So
Are you
please,
guys able to understand what I'm explaining?
I think they are understanding. Please put your thoughts in the chat so that the faculty will be understand about your that insight about this.
Can you guys understand what I am trying to explain?
Yeah, sir. Some people
Yes.
can't express by words, so we can read facial expression.
Yes, exactly. Yes, exactly.
Okay.
We'll have to assess their physical condition, assess their comprehension. Then only we can assess their pain. We'll have to see all the aspects: spiritual, uh, physical, spiritual, emotional, and psychological aspects. Then only we can address their pain. That is the next slide. We are going to the concept of total pain. Dame Cicely Saunders introduced the concept of total pain. Dame Cicely Saunders was a nurse. It is she who started palliative care. The concept of total pain is that uh, it which encompasses everything: physical, emotional, social, and spiritual dimensions. Our respected Rajagopal sir, Dr. Rajagopal sir, he also aptly puts it: pain causes more pain, and all pains are real. This means that when we address pain, we need to consider all these aspects. Also, we were talking about. Also, we were talking about how must we respect how each patient expresses their pain. When we talk about respecting how each patient expresses their pain, it's important to remember that everyone has a unique way of communicating their discomfort. For instance, we can imagine two patients with the same condition. Let's say they both have advanced arthritis. One patient might be very vocal about their pain. He might cry, he might frequently ask for medication, and he might constantly express how much it hurts. They might even cry or show visible signs of distress. It will be visible. They will be expressing it very much. On the other hand, the second patient, he might be more stoic. They may downplay their pain or avoid discussing it. Perhaps maybe it could be due to their cultural beliefs, it could be due to their personal coping mechanisms. What we have to do is, as healthcare providers, is it's very crucial to respect and validate all these expressions of pain. We should not assume that one patient is in more pain than the other solely on their outward expressions. Some might, the stoic one might have more pain than one expressing, than one expressing pain. But we shouldn't actually assume. That's the word. We shouldn't actually assume what the patient might be feeling, what the patient might have. We should never assume. Instead, we need to use thorough assessment tools and ask open-ended questions to understand their pain levels accurately. Can anyone know what do you mean by open-ended questions? What do you guys understand by open-ended questions? Yeah. Can anyone of you answer? Open-ended questions are simply, we can say, it will not be a yes or no question. eh? The patient needs to express. It shouldn't. Their answer shouldn't end in a yes or no. For example, we shouldn't ask. We have to- we can ask them, we can ask them, how is your pain? Please tell me about your pain. All these are open-ended questions. It will help us assess the pain accurately. We could assess the pain accurately. Pain usually also serves adaptive purposes, but also have adverse effects. Like one of you said, pain expression is also not limited to verbal communications. Yes. Now let's move on to the pathophysiology of pain. Pain begins with nociception, which is the detection of harmful stimuli by the nociceptors. The process involves four steps: transduction, transmission, modulation, and perception. Transduction usually happens from the first neurons. Neuroplasty or the ability of the neurons to change in response to new information or damage plays a significant role in pain modulation. You'll understand more of this by a video I'll be playing next. Correct.
Pain.
Yes, different types of pain. But we can differentiate all these pains into nociceptive pain, neuropathic pain, and also somatic pain and visceral pain. Nociceptive pain also includes somatic pain. These are pain sensations resulting from injury of tissues. Then neuro, like bone injury, tissue injury, then even visceral organ pain also can be nociceptive pain. Neuropathic pain, like you said, stabbing pain, king pain, uh, throbbing pain. These all are neuropathic kind of pains. These result from nerve damage, diabetic neuropathy, diabetic neuropathy. Yes, uh, it includes conditions like also it is also due to the abnormal functioning of our sensory neurons. With nociceptive pain, it's actually normal functioning of our it's a normal functioning of our sensory neurons. Neuropathic pain happens mostly due to an underlying condition. If there is a tumor in the brain, it can cause neuropathy. It can damage the nerves nearby, so it can cause neuropathic pain. There is no any external stimulus happening there. Similarly, alveodynia and hyperalgesia, these are terms denoting exaggerated feeling and exaggerated feelings. Heightened senses. And now we'll move on to somatic pain and visceral pain. Somatic pain, it's a localized, intense pain that is often described as sharp, aching, or throbbing. Accompanied also by, it could be or could not be accompanied by local muscle guarding or rigidity. Visceral, usually somatic pain patients are localized pain. They say yes, exactly. And even if it's radiating, they can pinpoint it out really well. Visceral pain, it's poorly localized, it's intimate in nature, and they'll say the pain is like key pain. It may also be accompanied by nausea or vomiting. Visceral pain is the most abdominal pain cases. What we see, those are visceral pain. Now, acute, like some of you said, acute and chronic pain. What is acute and chronic pain? Acute pain is short term and serves a protective function, often accompanied by physiological responses like tachycardia. Chronic pain, on the other hand, is long term, often non protective, and significantly impacts life. And that's the quality of life. Sorry. Now, we'll also see another video on a doctor examining a pain patient. Points you noticed? What was different from our usual consultations? What difference did you feel from this interaction? What difference did you feel? Yeah, is this what's happening in everyone's OP, in everyone's hospital? Is this the way every doctors speak? What have you felt different?
Please respond.
Yes, exactly. Listening to the patient. Yes, he made a good rapport with the patient. Yes, there was good interpersonal relationship. It was well maintained. Yes. Good. Yes, the doctor, she was listening actively to the patient. That's the main thing here. Uh, i- yes, exactly. She was actually listening to the patient. In our life, mostly everyone is eager to give advice. They're eager to give answers. No one wants to listen. So, what first you should do is you have to be a very good listener. Most patients where we see, they doesn't, the main problem for their pain is they doesn't have anyone to talk. In most patients, no, I wouldn't say most patients, but in some patients, after visiting them, after listening to them for a long time, they actually feel much relief. Their pain gets significantly reduced without any medications. So we'll move on to the we also a compassionate touch. It is also a very important point. uh, I think everyone noticed how uh, the doctor touched the patient's hand at the crucial moment. It also gives the patient or the caregivers hope that they can move on in life. Also, now we'll have to. This is the important part of pain assessment. This video, the interaction with patient, is also a very important part of pain assessment. Accurate pain assessment is very crucial. For acute pain, we often use tools like numerical scales. Uh, then for chronic pain, we use brief pain inventory, quality life assessment tools. Uh, Yes, these are the numerical. This is the first picture is the numerical rating scale. This is what we commonly use in our hospital in IP in our setting. This is what we most commonly use. Also, Wong Baker faces pain rating scale. This mostly we can give to patients who communicate non-verbally. Children, children. Visual analog scale, Magellan pain questionnaire. These all can also consider the impact on his daily life. You can also assess the quality of life he is getting uh, while going through this pain. Okay. Now, this is also a very important and very easy way to assess pain, PQRST assessment. This is what we commonly do in our hospital. Uh, the P represents precipitating and relieving factors or provoking and palliative factors of his pain. What makes the pain worse? What makes the pain better? And the quality of his pain. How would you describe the pain? What does it feel like? Look, see, these all are open-ended questions. So he'll try to explain his quality. Then the radiation of his pain. Is the pain in one place or does it move around his body? If it's in the just his lower, or is it radiating to his knee? Uh, then the site and severity. Where is his pain? On a scale of 0 to 10, how bad is his pain? On a scale of 0 to 10 means we should explain to the patients 0 is no pain and 10 is excruciating, unimaginable pain that no one can believe. That is the 10. If that is 10, how is his pain on a scale of 0 to 10? Most patients would answer the question. It would be easy for us for the follow-up assessment also. Most patients, first time when we explain and they say they have 8 out of 10. The next time when they come, they themselves say, "Sir, I have only 4 by 10 pain." It's very easy for assessment. Also, the timing. When did his pain start? What is the duration of his pain? Is it 3 months? Is it 1 year? Is it 10 years? Some people come with very long-standing pain. Then is it a continuous pain? Is it intermittent in nature? It just comes and goes for a few minutes, for a few hours, like that. What are the patterns of his pain? Is it constant or does it come and go? are you or have are then his treatment history. We should take the history also very meticulously. His treatment history should also be acquired if possible at all. Now, this is also a very important method which we assess and store the patient's records. We are human beings, we usually forget things. So, what we do here is mark their pain on this body chart. Uh, Importantly, we try to make the patients itself mark by themselves. That's what, because only the patient can explain or try to express his pain. We can't understand his pain. So therefore, we try and ask them to mark their pain in this body chart. So, what are the principles of pain management? What I would say is, in my perspective, it is to address his pain before coming to the pharmacological measures. We should first try the non-pharmacological measures. Effective pain management often starts with treating their underlying cause. Uh, it could be due to a disease. We should try to find what disease it is before we should manage his pain side by side also, but we should try to mitigate the cause which is causing the pain. Then we can move on to non-pharmacological methods like hot or cold application, like TENS, transcutaneous electrical stimulation, nerve stimulations, then relaxation or physiotherapy methods to manage his pain. Then we can move on to pharmacological management. For that, we usually follow the WHO analgesic ladder. This is the what is seated to your left is the WHO analgesic ladder. So, when after trying or genuinely along with that, uh, we start non-opioids for the pain. Along with the non-pharmacological measures, we start them with non-opioids. For example, paracetamol, brufen, even diclofenac, seclofenac, that can be given as non-opioids for a shorter duration of periods. If the pain is not reducing, it's persisting, he is not getting adequate relief, then we move on to mild opioids. For example, tramadol, tapentadol. And along with that, we can also use paracetamol as adjuvants or non-opioid medications. We can also add this to the mild opioids for added benefit. Then the pain is not, even then the pain is not adequate. He doesn't have adequate relief. Then we move on to the, mostly in a cancer patient, we move on to the third level, that is strong opioids. For severe pain, we can give strong opioids. Actually, there is no rule that you have to go by this step only. If it's a cancer patient with severe metastasis, we can directly move on to strong opioids if it's required. For example, morphine, fentanyl, methadone for the severe pain. If it's a non-cancer patient, what we actually do is before moving on to the strong opioids, we also try interventional managements uh, for addressing his pain, like nerve block, like that. So, what is the target of our pain control? We should achieve satisfactory pain relief. Our goal in pain control is to achieve satisfactory pain control and ensure that the patient is pain free during sleep and rest and movement. That should be our goal. But we should also remember to set realistic expectations. It is very crucial for both the patients and the healthcare providers. They should understand our limitations, potential side effects of the treatments. They should have a well understanding of the prognosis of the disease also. We should also ask them if they have an understanding of what we also should have an understanding of what they are expecting of us, of the healthcare provider, and also if are we able to provide what they are expecting. We should discuss this openly with the patient and also with the caregivers to achieve a target, to achieve adequate pain relief. So I think to summarize, we've covered definition of pain, its key features, the concept of total pain, pathophysiology, types of pain, and how to assess pain, and the uh, basic management of pain. So I guess everyone understood the class. If you guys have any doubt, to summarize also, we should keep in mind that we should keep the physical, emotional, social, and spiritual aspects of pain. It should be very crucial in your treatment, because only then we can improve the quality of life of the patients. Also, regular monitoring, adjustment of pain managements, and strategies which are necessary to ensure optimal outcome or optimal pain relief for the patients. So if you guys have any questions, now is the time you can ask.
Thank you, Dr. Ali, for the wonderful presentation. Anybody have any questions?
You can also share your experience regarding this topic, the experiences you've had with your pain management career or pain management where you're working. You can also share your experiences.
Anybody? No questions. I hope this presentation is clear to everyone. So before moving on to the case presentation, I would like to highlight few things. So pain, one of the most common symptom which we are facing in palliative care. The main aim of palliative care is to improve the quality of life of the patient and their family. Okay, if someone's suffering with pain, they come to you with pain. So it's our duty to reduce their pain, relieve their pain. Then only we can able to improve the quality of life. Okay. So the second most important of the aim of palliative care is to relieve pain and other symptoms. So these are the two major that points, the two major aims of palliative care, right? So today's session is on pain. What we need to understand is pain is a subjective symptom. So it's a subjective experience. So pain is what the patient says hurts. We need to believe the patient words. That we need to keep it in mind all the time. Sometimes they will not be able to express their pain through their facial expression. They can able to control themselves. So when we ask their about pain, they will tell you, yes, I am having pain. So through their from their facial expressions, sometimes we cannot measure their pains. We cannot identify their pain level. So that we need to keep it in mind all the times. We should believe their words. Okay. And the second, the point is how will we assess pain? Okay, so that also Dr. Ali was explained well. And before moving on to the assessment, we have to understand that what is total pain, physical pain, emotional pain, social pain, and spiritual pain. These all are correlated. If the patient is having psychosocial issues, psychosocial and spiritual issues there, definitely the physical distress will increase. Sometimes your medications will not help much because if they have a psychosocial issues. If they have psychosocial issues there, they will not be able to sleep properly. They will not be able to take the oral food. That emotional pain is also there. Okay, so we have to address the other parts also, not only physical aspects, we have to look into the other aspects also. Then only we can able to improve the quality of life. Okay, so if you have identified, definitely if they have a physical pain there, definitely we will try to relieve the physical pain first, give some analgesics, morphine trial or any analgesics. So after that, we have to look into the other aspects. You have to listen properly and give a proper attention to that aspects also. Coming to the assessment, there is a that alphabet STPQRST. So Dr. Ali was explained about PQRST. So I just added SD also. SD. S is site. Where is the site of pain? D is duration of pain. Duration of pain. Yeah. The P is palliative factor or a provocative factor. Q is quality of pain. What is the type of pain? Whether the patient pain is pricking type, stabbing type, or that burning type. These kind of disease comes under quality. So that R is radiation. So you have to ask whether that patient pain is radiating from one part to another. If the patient is having neuropathic pain there is these kind of features will be there. Radiating pain will be there because of the nerve compression. Okay, so you have to take a proper assessment on that also, because if the patient is having nociceptive pain and neuropathic pain, you have to treat both pain. Then only the patients will get adequate pain relief. So we have to do the proper assessment whether the patient is having nociceptive pain or neuropathic pain. And the another thing is severity. Severity we can measure it through 0 to 10 scale, numerical pain rating scale. If they are able to understand the numerical rating scale, you can ask them. 0 is no pain, 10 is most worst imaginable pain. So what? How do you score? So that person is the experienced person. The pain person is the best person to tell about his or her pain score. You have to give it this numerical pain score, pain scale with them. 0 is 0 is no pain. The 10 is the worst imaginable pain. They can able to tell you. And then if they are not able to understand the 0 to 10 scale, then the next option is the Baker faces pain rating scale. Okay, or visual analog scale. So these kind of things you can use for the measuring the pain. And the next is timing and the temporal factors is ADLS is activities of daily living is affected, or the patient is not able to sleep, or loss of appetite. These all comes under the temporal factors. So if you do like this, you won't miss anything. You can able to understand the pain level better. So if you do the proper assessment, you will be able to do a better plan, and then the patients will get benefited. So you have to keep it in mind all the time. So if you do the proper assessment, we can plan well. Through that plan, the patients will get better pain relief. Okay. And the next important point is doctor was said about two different types of pain, nociceptive pain and neuropathic pain. What is nociceptive pain and what is neuropathic pain? That we have to understand. So nociceptive pain is damage in the tissues. If there is any problem, if there is any damage in the tissues there, so that called nociceptive pain because of the tissue damage. If that pain, sometimes the tumor will be compressing the blood vessels, the damaging of the nerves there, then the neuropathic pain. So these are the two major differences of pain, nociceptive pain and two different types of pain, nociceptive pain and neuropathic pain. Nociceptive pain again divided into two, visceral pain and somatic pain. So somatic pain is this pain in the muscles, bone, and other soft tissue, skin, these kind of things comes under somatic pain. So the visceral pain is because of the capsular stretch, liver capsule stretch, or pleural effusion. So the covering of the lung is pleura. If there is any fluid accumulation there, the viscera will expand. No, so that time the patient will experience chest pain. maybe sometimes they can, if they take breathe, the patient experience pain. So that is comes under visceral pain. So that we can able to identify, we have to differentiate the type of pain. So based on the type of the pain, you have to treat. So that is very, very important. So now today's session is about introduction to pain and the assessment of pain. The next session is on management of pain. That time we will discuss more about the management of pain. Based on the pain score and the type of the pain, we will treat pain. So according to the WHO analgesic ladder. So that was also Dr. Ali was explained well. Okay, so we will discuss about the WHO analgesic ladder about in later days. Maybe tomorrow we will be discussing about WHO analgesic ladder step 1 and step 2. Okay. So I think we can move on to the case presentation. So Miss Kavita Pavane will be presenting a patient story. Miss Kavita, is over to you.
Yes, ma'am.
Kavita, can you able to see the slides?
Yes, ma'am.
Okay.
Can I start?
Yes, you can start.
Good afternoon, everyone. Today I'm going to start my case presentation. Kavita Pavane. Ma'am, next. My patient is 55 years old male. He is diagnosed with traumatic equilateral with second stage of bed sore with gluteal region. Then present complaint of my patient is he is 55 years old male having severe pain, then difficulty in eating, then difficulty in his doing daily activities. Then history of illness. He had history of fall from tree followed by pain and both limb weakness and diagnosed with traumatic equilateral in December 2023. He got admitted and treatment
Kavita,
and discharged after 1 month. 3 months, he got bed sore over the hip region due to bed sore. Then he had a disturbed sleep pattern.
Kavita, now you are audible. Your voice was breaking. So that's why I was calling.
Oh, okay, ma'am.
You can continue.
Then history of fall from
Kavita, Kavita,
by pain and both limb weakness. And 2023, he got discharged after 1 month. Yes, ma'am.
yeah, your voice was breaking that time. Now it's clear. Okay, carry on.
After 3 months, he got bed sore over the gluteal region, then history of pain over the hip region due to bed sore. Then he had disturbed sleeping pattern, impaired physical activity, and imbalanced nutrition. Then on examination, he was conscious and oriented, temperature 97.8 Fahrenheit, then pulse 72 beat per minute, respiration 20 breath per minute, then BP is 110 by 70 mm of Hg. Then bed sore was foul smell, irregular in shape and numbness. Treatment and significant investigation, routine investigation done. HB was 11.3, then platelet count 1.8 lakh and total count 36,000. Then psychological aspects, 55 years old man married man living with his 50 years old wife and his own house. He had 3 sons and 3 daughter-in-law and 7 grandchildren, and they are living separately and not caring. He is labor worker and breadwinner of the family. Now his wife is doing labor work and taking care of him. Now the main source of income from daily wages and younger son. He says to his wife, I don't think I can walk. Please don't waste money on my treatment. Then medication, tablet diclofenac 50 mg. Main concern was pain and bed sore. Then summary, move to the summary. 55 years old man with traumatic equilateral with second stage of bed sore over gluteal region with hip pain. Discussion point, what problem can faced by patient and his wife? Then what can be done for this patient? Can provide palliative care.
Thank you, Kavita, for the wonderful patient story. I hope
Thank you.
this presentation is clear to everyone. If anyone wants to need any clarification regarding this patient story, please ask her. Otherwise, we can move on to the discussion points. Okay, we can move on to the discussion points. How many of you agree with that the last question is, can we provide palliative care for this patient? How many of you agree? The third question is, can provide palliative care for this patient? Agree. Agree. So everyone is agree, this patient need palliative care, right? Okay. So today mainly we discussed about pain. This patient main concern is pain and bed sore. We are focusing on pain today. So I would like to hear from you all. How can we do the better assessment of pain for this patient? So what all things we can assess? So we can start with yes. Where is the site of pain? Kavita?
Yes, ma'am.
Yeah. Where the site of pain? I was just ask you about the site of pain.
Ma'am, gluteal region, left.
Gluteal region. Okay. So what was the duration? Do you have any idea? No idea. So I think you are all familiar today about pain assessment, STPQRST. So hereafter, you have to, when you come with a patient story, you have to be give a write the proper pain that assessment. Okay, so then only we can able to understand the pain types, score, and that quality and all. So these we need to understand for treating the pain. So always you have to keep it in mind while assess the while we send the when you before you send submit your case presentation, please add that points also. Okay. So again, one more question. Do you have any idea about pain score, or this patient is having adequate pain relief with diclofenac? This is my question. Dr. Ali, do you want to ask anything?
No. Continue.
Okay. Kavita, my
Yes,
question, yeah, my question is, this patient is get pain relief with diclofenac or not? Now, what about
no,
the pain score? Any idea?
ma'am, I can't hear.
You can't figure out. Okay. So, usually what we do, if you give some pain medications, we will assess, right? We will check.
Yes,
We will do the follow-up, right? We will reassess after 1 hour. We will go to the patient side, and then we will ask them whether the patients that the pain relief is adequate or not, if that medication is helpful or not. Is that correct? We are
yes, ma'am.
nurses. We are spending more time with the patient, right?
Yes, ma'am.
Doctor will be prescribing the medications. We are the person to carry out the medications, right? After that, it's our responsibility to reassess the pain. That particular medication is helpful or not, right? If that medication
Yes,
is not give a sufficient pain relief, it's our duty to inform to the particular doctor. Doctor G, this medication is not helpful. This pain is again, the patient is again complaining of pain. So you have to tell about the patient, the pain score also. Sometimes 9 by 10, sometimes 8 by 10. After that medication, sometimes that pain score come down at 5 out of 10. That also you can inform to the doctor. Then only the doctor will rethink about is there any medication added or is there any medication change. So these kind of things, right? So these all comes under from us, right? We have to think about that. We need to do the proper assessment, right?
yes, ma'am.
What you also have to keep in mind is that when we are giving pain medications, for it, we should give it by the clock, by the time. Uh, we have to keep in mind that we should know an average estimate of how much time will the medicine, what's the half-life of the medication. For example, if you are giving morphine, we have to give it by the clock. Every 4 hours, we'll have to give them morphine because morphine will only act for 4 hours. So that you have to give it. It's the same for every medication. Even if it's paracetamol, if you're giving paracetamol for pain, you should give it 6th hourly or 8th hourly, or the minimum if they still have pain. If their pain is persisting, you will have to give it 6th hourly. That you have to keep in mind.
Uh, Madhubhai, yeah, is saying like physiotherapy for pain relief. What kind of physiotherapy do you advise for pain relief?
Actually, we have mobilized a little bit pain control for pain control.
Yeah, what kind
But
of
the person can mobilize not too much, but a little bit, so that the blood circulation will go through well. That may help to pain relief. I just thought about this.
Okay, so yeah, usually if the patient is having severe pain, usually we cannot do anything for physical activity because they will be in severe pain. So it's our duty to reduce their pain, give some medications or devotional activities. Okay, sometimes yeah, that also if the patient is having severe pain, we can't. So better you don't do physiotherapy that time. Once the pain comes control, then you can under control, then you can do some physical activity, encourage the patient to do some physical activity. If you that also sometimes the provocative factor. Maybe sometimes if they do some activities, that pain will increase, right? So we based on that you have to think whether the patient is needed physiotherapy or not. Yeah, tell me.
Thank you, ma'am.
Yeah. Anybody wants to add any points? Can we go back to the psychosocial aspects? So today we have discussed about the four aspects of pain: physical pain, emotional pain, social pain, and spiritual pain. The total pain concept is brought out by Dr. Dame Cicely Saunders. She is the person to brought out the four aspects because we if we don't give attention to that all aspects, that patients will not get good pain relief. So that is why we need to give a proper attention to those areas. So physical problems, okay, we will treat. Definitely, if they have any physical distress, they will come to you, right? Usually we all are focusing on the physical parts, and we will try to reduce their suffering only the physical aspects, right? So in addition to, we have to think about the other aspects. Okay, here this is the psychosocial aspects. So what all things you have identified from here? What are the psychosocial issues? Everyone, please unmute yourself and talk, or you can put your answers in the chat box. Just imagine 55-year-old man. Yeah, financial unstable. Okay, financial problem will be there. So that will be affecting the patient emotionally and socially. Then so dependency, he is not able to do his own things independently. Always need to depend others. So that making emotional worries. So emotional disturbance is always there. I also he said like I don't think I can walk. Please don't waste money on my treatment. So these are yeah, role of change. Yeah. So he was the breadwinner of the family. Now he can't. He is bedbound. He is not able to do anything for his family. So that will be affecting the patient emotionally. So how can we manage? These all are issues. So what we can do is we have to we need to do the proper listening. So we need an empathetic mind to listen their worries. So we have a session on communication. So that time we will discuss more about that. So we have to understand their emotions. We have to listen their emotions. We have to sit down and listen. So once they explore their emotions, Then only we can understand their insight, and based on that we can able to give a psychosocial support, or we can give some another options also. So that we have to keep it in mind all the time. So psychosocial aspects, the social aspects, what all things, the negative thoughts. Okay, definitely. So why I'm living like this? So these kind of things will be there. Suicidal thoughts will be there. So if we do the assessment, definitely if you have a proper rapport with the patients, they will start tell. Okay. So the family members also, there sometimes they feel burden. So that patient also feeling like, oh, I'm burden to the family. These kind of things will be affecting the patient emotionally. So, and also Madhuri is saying like he is living with his 3 sons, but they are not caring. So emotional disturbance. Yeah. So that is the another problem. What we can do is we can talk to the sons, the childrens, why they are not caring. Is there any problem? Is there any relationship issue? Is there any family problems or any things there we can try to solve? So I know we don't have enough time for spend these kind of things, but at least you can able to identify the issues. If you have a psychosocial, maybe medical social MSW, medical social officers there or psychologists there, you can connect with them. So there will start the teamwork. Okay, so the doctor will be prescribing the medications, and the nurse will be carry out the medications, and your responsibility to recheck or reassess the pain score or any other problems there. Your duty to address that issues, and you can connect with others, right? Then we can able to help. So teamwork is also important here. So that kind of thing, social. Sometimes before that, the neighbors and relatives and friends was used to support to this family. So after this disease, nobody is willing to take care of him, and nobody is willing to see this patient. So this will be affecting the patient emotionally. Social isolation. Okay. And finally, spiritual issues. But spiritual pain will be there. Why God punished me like this? So these kind of things. What we can do is you have to understand the pain as total physical, emotional, social, and spiritual, and also you have to sit and listen their problems. Sit down and listen. Once you can able to understand their problems, then it's very easy to treat them. Definitely panchayat can help. If the community is not help, definitely you can connect with the community volunteers, or you can connect with the ASHA workers, or you can connect with that NHM staffs, non that National Health Mission staffs. So they can able to help them. So these kind of things you can do. Yeah, definitely. NGO help if they have any nearby NGOs, palliative care NGOs there. Definitely you can connect with them. So they will support. So the palliative care team will go there and support them. So this is a teamwork. What we need to understand that the teamwork is very important. At the same time, we look into the 4 aspects. So try to solve their problems so that we can able to improve the quality of life. And we have to understand the family, the caregivers' emotions also, because from the first day onwards, the caregiver is also suffering. We have to understand their emotions also. They are not able to spend time for themselves, so that will be affecting them emotionally. So we have to explore their emotions also. We have to support them also. Okay. So from the first day class itself, you understand that palliative care is not only for patients, it's for family. So we have to treat the patient and as well as the family. So then only we can able to improve the quality of life. Okay, thank you. Dr. Ali, you want to add anything? If you don't comment anything, we can wind up. Or others. So if you don't have any questions, we can wind up today's session.